Hello, my name is Dr. John Gillespie, and I am the Clinical Director of Sil Biotech Incorporated. Today, I am going to give a presentation on BBDRisk Dx test, which stands for Benign Breast Disease Risk Dx. And this is a genomic test for making informed treatment decisions for women who are diagnosed with atypical ductal hyperplasia. This is our logo. Before giving the presentation, I would like to first acknowledge all the professionals who have contributed for developing the BBDRisk Dx test. First and foremost, most of the financial support for developing the test came as grants from the NCI and NIH, and funding also came from the Susan G. Komen for the Cure and the National Science Foundation. Dr. Pula was the PI on the grants. We would also like to acknowledge the collaboration of breast surgeons, breast pathologists, statisticians, and molecular biologists from several institutions as shown here. I have been with the company for the past 5 years, and I have been reviewing the histology of the tissue as well as scoring the immunohistochemistry slides. We would like to address the dilemma faced by oncologists in managing breast atypical hyperplasias. Studies show that in at least 1 in 5 women develop breast cancer amongst this cohort. Currently, standard histology cannot distinguish those who will develop cancer from those who will not develop cancer. As you can see here in the top picture, atypical hyperplasia from a patient who did not develop cancer for at least 5 years is histologically indistinguishable from the bottom picture of atypia from a patient who subsequently developed cancer after 2 years. Since there is a lack of any tools to distinguish those who will develop cancer from those who do not develop cancer, there is a dilemma of who to treat. In the first option, if all patients diagnosed with atypical lesions are treated with risk-reducing agents such as tamoxifen or aromatase inhibitors, 80% of them who would not otherwise develop cancer would be subjected unnecessarily to side effects, which could be quite significant, or if no one is treated, in which case about 20% of the patients will miss out on the benefit of prevention. We at Sil Biotech have recognized the need for a tumor biology-based genomic test for making informed treatment decisions while managing breast atypical hyperplasias. The test development was based on state-of-the-art cutting-edge molecular approach. The test was developed in the following stages. First, we identified over 300 putative cancer predictive markers by gene expression studies. Next, we screened several markers that were identified from the gene expression studies and validated selected markers in sets of cases and control groups of hyperplastic tissues. Third, from the marker validation data, we developed a multi-marker test that predicts the cancer development with high sensitivity, specificity, positive predictive value, negative predictive value, and accuracy. Fourth, we then established the validity of the test in independent sets of cases and controls. Finally, we developed the technology for clinical application. To develop the test, we first hypothesized that the hyperplastic tissues from women who develop cancer are true precancerous lesions and have elevated expression of a number of cancer-promoting molecules. This is the premise for the test development. The hypothesis is shown schematically in the figure here. If the cancer-promoting molecules are present in an atypical hyperplasia, then it is a true precancerous lesion and will then go on to develop cancer. To test our hypothesis and identify the cancer-promoting molecules, we performed the state-of-the-art gene expression studies of atypical hyperplastic tissues from subjects who subsequently developed cancer in comparison with tissues from subjects who did not develop cancer for at least 5 years and above. By this approach, we identified over 300 cancer-promoting molecules that were highly elevated in atypias from subjects who subsequently developed cancer. The elevated molecules can be seen in the heat map here. In the upper left, all the elevated genes can be seen in red from the tissue of those who developed cancer in comparison with the tissues from patients who did not develop cancer, which are shown in green on the right. Of the 300 elevated genes identified by gene expression studies, we selected 6 molecules for screening and further validation and test development as shown in the table. These markers were selected because they are highly increased several-fold and are also established promoters of cancer progression. For example, CEA CAM6 was elevated 37-fold and is an established promoter of progression of GI cancers, breast cancer, and several other cancers. The total number of samples used for the test development was 550, in which 250 samples were from subjects who subsequently developed cancer after a minimum of 1 year and a maximum of 13 years. And the other 300 samples were from subjects who had no prior breast cancer history and did not develop cancer for a minimum of 5 years and a maximum of 19 years. These samples came from 4 prominent institutions as shown here. Based on the best performance, the following markers were used in the development of the test: MMP1, CEA-CAM6, HIL1, and HEC1. This is to show examples of immunohistochemically stained slides for the 4 markers and ESR1 in atypical hyperplasias, non-atypical hyperplasias, and cancer tissues. We show here the sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of the BBDRisk Dx test. All the values are in the 90s range and an accuracy is 91%, which is very high. How was the test performed? Briefly, the BBDRisk Dx test involves assaying 4 cancer markers in hyperplastic tissues by immunohistochemistry in standard formalin-fixed paraffin-embedded tissue sections. Based on the marker levels, a cancer risk score from 0 to 10 is calculated using our proprietary algorithm. This classifies a patient as low risk, which is from 0 to 0.5, intermediate risk, greater than 0.5, less than or equal to 5.4, and high risk, a score of above 5.4. In this slide, we show a Kaplan-Meier cancer-free survival curves for low risk, intermediate risk, and high risk subjects to evaluate the cancer rates amongst these groups. As you can see, the low risk group in blue, who scored 0.5 or less, did not develop cancer for the first 5 years and over a 19-year period of time. The cancer-free survival is 97%. In the high risk group in red, who scored above 5.4, the cancer rate in the first 5 years after atypia diagnosis is about 73%, and by 15 years, almost everybody developed cancer. Among the intermediate group in black, who scored between 0.5 and 5.4, a small percentage, 12%, developed cancer in the first 5 years after atypia diagnosis, and increasingly modestly to 20% over a period of 15 years and beyond. Overall, the Kaplan-Meier curves show a clear separation of low-risk group who are not likely to develop cancer from the high-risk group who are most likely to develop cancer in the first 5 years and beyond. Here we show numerically the cancer rates among the 3 groups in the first 5 years, 10 years, and beyond, and have applied the BBDRisk Dx for non-atypical hyperplasias. In this group, we have shown that 1 in 10 patients develops cancers within 5 years or beyond. Here, the sensitivity, specificity, positive predictive value, negative predictive value, and accuracy are comparable to atypical samples. Kaplan-Meier cancer-free survival analysis shows that among the low-risk group, the cancer rates are 3% or less over a period of 19 years. Among the high-risk group in red, the cancer rates are about 34% in the first 5 years after diagnosis, and by 15 years, most develop cancer. In the intermediate group, the cancer rates are very modest and did not significantly increase over time. Overall, the lower rates in the non-atypical group in the first 5 years among the high-risk group suggest a slower growing cancers. The cancer rates are shown numerically in the 3 groups at 5 years, 10 years, and beyond. We would like to establish here that the number of samples used for test development have sufficient power and significance. The total number of samples used was 550. The odds ratio for the combination of 4 markers was 8.4. Based on the odds ratio of 8.4, the sample size required to give a power of 99% with significance level of 0.001 was 102. Therefore, a sample size of 550 is sufficient for the test development. And then we go to the publications on the test development. We have published the gene expression studies and validation of one of the markers, MMP1, in Nature Medicine, and the validation of another marker, CEA-CAM6, was published in Clinical Cancer Research. And we published the validation of a third marker, HIL1, also in Clinical Cancer Research. And the validation of the above three markers and an additional marker, HEC1, in independent sets of samples was submitted to Cancer Prevention Research and has been accepted for publication. And here we show that the BBDRisk Dx test can be easily integrated into the clinical oncology practice as seen in this flow diagram. Here the radiologist identifies a breast mass by mammography or MRI, and the patient is referred to a surgeon for a biopsy. The surgeon removes the mass that is then sent to the pathologist, who renders a diagnosis of atypical or non-atypical hyperplasia. At that point, a breast surgeon, medical oncologist, primary care physician, or even a gynecologist who may have detected a mass during routine exam can order the BBDRisk test, and the pathologist sends us tissue slides cut from the formalin-fixed paraffin-embedded tissue blocks. We will provide the kits for shipping samples and postage-paid envelopes. We will perform the test and send the report to the ordering physician. In the report, the results are presented as a risk score, and depending on the risk score, we will categorize the patient as low risk, score of 0.5 or less, intermediate risk, greater than 0.5 or less than 5.4, or high risk, a score of more than 5.4, as shown here. As shown here, the BBDRisk Dx test can stratify a high-risk group from low-risk group for making informed treatment decisions. Only for discussion purposes, we have shown some disease management options here. In this slide, a sample report is shown. The results will be presented as a risk score. In addition to the risk score, the report will also show a graph whether the patient with a given risk score is placed under low, intermediate, or high risk. In this report, a risk score of 4.1 is categorized under intermediate group. We will compare the given risk score with a plurality of risk scores in our database and present the percentage of patients with a given risk score who have developed cancer as a cancer rate. In this case, 38% of people with a score of 4.1 subsequently develop cancer. We will also show confidence intervals in dashed lines as seen in the graph, and the results report will also provide a brief description of our validation study. BBDRisk Dx is regulatory compliant. It is a laboratory diagnostic test, or LDT, and LDTs are not regulated by the Food and Drug Administration. Also want to point out the Oncotype DX test by Genomic Health is also not FDA regulated. And the BD is CLIA regulated, and we are CLIA approved and licensed. I am the clinical director, and the turnaround time for the test is approximately 2 weeks. To order the test, you can send 5 to 6 unstained tissue sections cut from the FFPE blocks onto charged slides, or you can send the blocks to us and we will cut the tissue sections and then we will return the block. Also, we require the test request form signed by the physician, as well as payment and insurance information. BBDRisk Dx test coverage is approved by major private insurance agencies as listed here, as well as by the CMS. And you can learn more about the test from our website, YouTube's, and other media as shown here. If you have any questions or need more information, please email us at info@bbdrisk.com. And we thank you for your attention.